Okay, hello everyone. This is our group. We had the topic pancreatitis, and in the group was Geraldine, Grace, Renee, and Tara. Tara, and we're going to be discussing how it presents, what to look for, the etiology and pathology behind it, and clinical manifestations. So to begin, what is pancreatitis? Pancreatitis can be broken into two categories. Acute pancreatitis is acute inflammation of the pancreas. This is associated with severe pain because pancreatic enzymes spill into the surrounding pancreatic tissue. Chronic pancreatitis is chronic ongoing inflammation of the pancreas, leading to fibrosis of the pancreas. This may also involve strictures and/or calcifications. So the etiology and pathology of acute pancreatitis is associated with some specific pre-existing conditions, diseases, or habits, but it can also occur randomly. Idiopathic pancreatitis exists as well. We often see pancreatitis in patients with alcoholism, biliary tract disease, trauma, infection, drug use, or post-operative GI-related surgeries. And these etiologic factors can lead to two specific types of reaction in the pancreas: activation of pancreatic enzymes and/or injury to pancreatic cells. When either of these responses occurs, it creates what is known as autodigestive effects of the pancreatic enzymes. And this is where the injury of the pancreas is seen. Trypsin causes edema, necrosis, and hemorrhage, and these are the enzymes that are released. Elastase is associated with hemorrhage. Phospholipase A and lipase are associated with fat necrosis. And kallikrein is associated with edema, vascular permeability, smooth muscle contraction, and shock. So those are some of the things that we might look for, like when we're running labs. If they have these elevated levels, we might be looking for things like hemorrhage, edema, or smooth muscle contraction. For chronic pancreatitis, this is often seen with patients who either have a history of acute pancreatitis. They might have a tumor, pseudocysts, systemic diseases such as lupus, autoimmune pancreatitis, or cystic fibrosis. The chronic pancreatitis can be broken up into two specific categories, and that would be non-obstructive pancreatitis. And this is most commonly seen with chronic alcohol use. The inflammation and sclerosis occur mainly in the head of the pancreas and around the pancreatic duct. Obstructive pancreatitis is most commonly caused by gallstones, and the inflammation is seen primarily in the sphincter of Oddi. Cancer of the ampulla of Vater, the duodenum, or the pancreas can also cause chronic obstructive pancreatitis. Next, Geraldine is going to talk to you about the clinical manifestations.
Hi everyone, I'm Geraldine. I just want to give you a quick summary of the manifestations, subjective and objective, in pancreatitis and the diagnostic tests that are used to diagnose pancreatitis. Symptoms can be reported as upper abdominal pain that travels usually through the back and is made worse after eating a meal or after eating high-fat foods. Pain can worsen when the patient is lying in a supine position, and the patient will also report that they've lost weight or they have diarrhea. And the reason for that is because of the malabsorption of their food. And also, diabetes will develop if the insulin-producing cells of the pancreas are damaged. So they'll also be reporting signs that may seem like they have diabetes. Also, other symptoms will be nausea, vomiting, fever, and they will report an increased heart rate. And signs of pancreatitis are swelling of the pancreas that can be seen in the diagnostic tests, fever, tachycardia, and they will also have a swollen abdomen, and they'll also be guarding their abdomen. There will be hyperactive bowel sounds, and they'll have jaundice. You'll notice dyspnea because of the irritation of the diaphragm because of the inflammation. And also, they'll also have hemodynamic instability, which is unstable blood pressure. The patient will be pale, you'll see them diaphoretic, and they'll be listless. Tests will show lesions of the stomach and the duodenum, and diabetes will develop because, as I said, the insulin-producing cells in the pancreas are damaged at this point. Also, pancreatitis generally is suspected when the patient has symptoms and risk factors such as heavy alcohol ingestion. And diagnosis today for this is aided by a number of new techniques, where before it was a little bit difficult to diagnose pancreatitis. But today, doctors will diagnose pancreatitis by measuring the blood of two digestive enzymes, which are amylase and lipase. And high levels of these two enzymes will strongly suggest pancreatitis. Doctors may also use other tests, such as pancreatic function tests, to find out if the pancreas is making the right amount of digestive enzymes. They'll also do a glucose tolerance test to measure damage to the cells in the pancreas that make insulin. They will also use an ultrasound, CT scan, and an MRI. And these, of course, make images of the pancreas so that problems may be seen. And endoscopic retrograde cholangiopancreatography will be used to look at the pancreatic and the bile ducts. And they may also biopsy by inserting a needle into the pancreas to remove a small tissue sample for study. And in advanced stages of the disease, doctors may also use blood, urine, and stool tests to confirm the diagnosis. So I hope this helps, and you guys have a great day. Thanks.
Okay, go ahead.
Okay, and this is Renee McVandy, and my portion is the collaborative care of pancreatitis. And basically, the care that we need to do is pain control, because it causes a lot of pain. The next is to prevent any shock from occurring, reduction of pancreatic secretions, fluid and electrolyte imbalance, prevention and treatment of any infection, and the removal of the precipitating cause. Now, the pain management is basically number one, because we want to get pain under control with any patient, and that helps them rest and heal in the hospital. And so next I'm going to be going on to the drug treatment. Okay, so the treatment that is basically used for pancreatitis is morphine. And of course, we're all familiar with morphine. It can be given intravenously, it can be given oral, sub-Q, and every 4 hours. It could be as early as 2 hours and all the way as every 6 to 8 hours. PRN, and that's for severe pain, usually when they rate it from 7 to 10. And basically the way morphine works is it binds to opiate receptors in the central nervous system, which alters the perception of the pain. So it's pretty potent stuff. So it's very helpful for pancreatitis. And the next treatment that is used is the antispasmodic, I believe. And this one is the dicyclomine. It's also known as Bentyl, and that basically helps decrease the secretions of your stomach acids into the duodenum. So it reduces your GI motility and the tone in your GI. So it's very helpful in helping the pancreas heal, so it slows down all motility, and that can be given orally or intramuscularly. And the next one obviously is the antacids, and that is your Tums, the calcium carbonate. There's quite a few different kinds, and that's basically to neutralize any acids in your stomach, because we want the stomach to slow down, everything basically to slow down, so it kind of neutralizes the acids and decreases the production and secretions of the pancreas, the enzymes that the pancreas makes, but we want to slow all that down. And next would be the PPI, the proton pump inhibitors, and this is the one I got familiar with in clinicals. It's called Protonix. Pantoprazole is the official name of this one, and basically that is used to prevent the acids made in your stomach to slow down. It's to prevent it from entering the gastric lumen, and it's like a coating is basically how I see it. So they use that quite often in pancreatitis situations. And lastly is the insulin. Since the pancreas is healing, or I guess you would say damaged, or the cells that make your insulin are damaged, so our blood sugars go up with our pancreatitis patients, and so we use insulin to help bring down the blood sugars so they don't get too bad or out of control. Okay?
Okay, next slide. Okay, go ahead. Hi, this is Tara. I've got the nursing diagnosis for you for pancreatitis, and they include acute pain related to distension of the pancreas, peritoneal irritation, obstruction of biliary tract, and ineffective pain and comfort measures. Deficient fluid volume related to nausea, vomiting, restricted oral intake, and fluid shift into the retroperitoneal space. Imbalanced nutrition, which is less than body requirements, related to anorexia, the dietary restrictions, nausea, and loss of nutrients from vomiting, and impaired digestion. Ineffective self-health management related to their lack of knowledge of preventive measures, diet restrictions, alcohol restriction intake, and follow-up care. Okay, don't start again. Hi, this is Tara again, and I have the potential complications. And the severity of the disease and complications varies due to the extent of the disease. While some patients recover completely, some have recurring attacks and others have life-threatening complications. Two significant local complications are pseudocyst and pancreatic abscess. Pseudocyst is a collection of fluid and tissue debris around the pancreas along with inflammation. This causes significant pain, nausea, and vomiting, and may require surgical drainage. A pancreatic abscess is a collection of pus resulting from the necrosis of the pancreas causing high fever, pain, abdominal mass, and leukocytosis. This requires prompt surgical intervention to prevent sepsis. The main systemic complications from acute pancreatitis are pulmonary, including pulmonary effusion, atelectasis, pneumonia, and acute respiratory distress syndrome. Among the systemic complications, the pulmonary complications are the most frequent and the most serious. A patient with symptoms of hypoxia, tachypnea, and mild respiratory alkalosis are associated with increased mortality. These complications are most likely due to the passage of exudate containing pancreatic enzymes from the peritoneal cavity and inflammation of the diaphragm. A patient is at risk for intravascular thrombi, pulmonary emboli, and disseminated intravascular coagulation. Cardiovascular complications and tetany are due to hypocalcemia that is due to the combination of calcium and fatty acids during fat necrosis. Hypocalcemia is an indication that the disease progression is severe. In patients with acute necrotizing pancreatitis, infection is the leading cause of morbidity and mortality. And that concludes our presentation. Thank you.